The Anatomy and Biochemistry of Affective Illness on Audio Digest Psychiatry, Volume 24, Number 9, the second of 2 consecutive hours on this much-requested subject. On your last issue, Terrence Ketter, National Institute of Mental Health, spoke about the pharmacology of depression, and he continues the topic now with remarks on oral loading of sodium valproate.
You can give 10 milligrams per kilogram in the first day. Paul Keck and Sue McElroy showed some nice data of this, and get people loaded up with valproate fairly quickly when they're in the manic state. If you try to do this with the other 2 mood stabilizers, there's a chance that you're going to get more in the way of neurotoxicity. But it looks like you may be able to get away with this. Now, the problem is, if you're overly aggressive at the front end, you may spare people neuroleptics, you may get more rapid control, but if people get a lot of side effects and make bad associations with the medicines, you may pay for it down the line. Carbamazepine, so it's the renegade tricyclic. It's the tricyclic that does everything except what a tricyclic ought to do. It is not a major reuptake blocker of monoamines. And what we have with carbamazepine is a number of response predictors that have overlap with valproate, and really a set of novel side effects, perhaps 10% rash and drug interactions, rare but dangerous decreases in white blood counts. So this medication takes a little bit of clinical finesse to work with. Some of the best monitoring for hematological side effects is in fact clinical monitoring. And therefore monitoring for infections, fever, fatigue, bruising, bleeding, and such is the best sort of monitoring. And certainly patients who come out at the front end with low counts, you have to watch them carefully. But anybody who's on carbamazepine needs to be warned that if they get any of these symptoms, they need a CBC checked. And of course, people are going to be getting the flu, but you want to be sure that they aren't dropping their white count. So this is a nightmare. Carbamazepine is the bad boy of drug interactions. What we have here is a parent drug that is active. We've got an active metabolite that doesn't show up in routine assays, and then another inactive drug. You're trying to figure out why the person's toxic on the same dose of carbamazepine with a little valproate added. So there's a drug interaction with valproate you need to pay attention to there. There's a series of drug interactions. There's a number of compounds that can bump the carbamazepine level, and at least you'll know what's going on because you can see it in the level. But you have a patient who gets cold or something like that, and they get put on erythromycin, they'll be toxic, potentially toxic. A number of medicines, non-dihydropyridine calcium channel blockers, fluoxetine. It's a real grab bag of medicines. Other things can induce this system, including carbamazepine itself. So that a month out, you may need twice as much as you needed the first week. Well, our colleagues in molecular biology have helped us out with figuring out some of the specific isozymes that are involved in these reactions. And you may have heard of cytochrome P452D6. Okay, it's an important one, but in fact, the one that ultimately may be the most important is one called cytochrome P453A4. And earlier this year, it was proved by molecular methods, and these include taking these genes, cloning the genes, putting them into yeast, expressing them in vitro, and then metabolizing drugs through them and interfering with metabolisms with the antibodies to the enzyme. And they figured out that carbamazepine goes through this system. And in fact, all these other medicines do. And they include steroids, they include sex steroids, so thinking of birth control pills and having levels of birth control pills go down with carbamazepine and inefficacy, we can explain that. An awful lot of these interactions. This holds not just for carbamazepine, but for drug interactions in general. In the future, I think we'll be able to think in terms of substrates, inhibitors, and inducers for each of these different systems. And if you have 2 drugs that are within a category, there's a chance of an interaction. So carbamazepine is a substrate. Inhibitors can block its metabolism, and it's also an inducer, so it can induce the metabolism of these substrates. And depending on relative affinity, you can either have or not have drug interactions. So we're looking at a whole new era of predicting drug interactions and understanding drug interactions. This is a chronic illness. We got to talk people into taking medicine when they're feeling well that makes them feel unwell. And really, it's incumbent upon us to try to tailor the therapy to make it as user-friendly as we can. And if somebody is being lithium non-compliant, even if they've had a good lithium response, and you're getting breakthroughs due to documented non-compliance, it really would behoove you to look at the alternatives, and it may be there's something more palatable about that. So if somebody has a tendency to gain weight, you may find that carbamazepine would be preferable to the other 2 agents. Same if there's a lot of tremor. On the other hand, if this person, all you have to do is look at them and they'll have a rash, this may not be the best choice. If there are hepatic problems, these two may be less likely to be the prime agent, and so on. So looking at the patient's relative medical strengths and weaknesses, looking at the agents, looking how they go together. You see a number of overlaps between lithium and valproate, weight, tremor, and so on. So you really want to try to tailor these medicines to the individual patients. Unfortunately, combination therapy is often needed, and you can take combinations of lithium plus carbamazepine or lithium plus valproate. Dr. Post showed a patient with carbamazepine plus valproate. Sue McElroy and Paul Keck have reported 4 cases. And Mauricio Toan up in Boston has done a retrospective series of a number of these cases. The important thing in this is to remember that enzyme induction can drive down valproate levels, and valproate not only through a binding interaction, increasing free carbamazepine levels, but also inhibition of epoxide hydrolase can increase the metabolite. So a strategy probably would be to decrease carbamazepine dose and increase valproate dose and try to get low therapeutic levels of both of them. This is the other part of the illness, and we spend an awful lot of time fighting depression with mood stabilizers. And certainly with some of their limited antidepressant properties, we do have success. But ultimately, there are patients that will not respond to 1, 2, or even 3 mood stabilizers in terms of an antidepressant response. And what are our options then? Well, there's tricyclic antidepressants, which can cause manic switches and are heavy on side effects. Can be lethal in overdose, so that may not be the best way to go. There's MAO inhibitors. There's only 2 of them now. There is good data that suggests that parnate, trilacipramine, is superior to imipramine in bipolar depression. And if you think of bipolar depression being like atypical depression, being hyperphagic and hypersomnic, MAO inhibitors probably make sense on that basis. However, they can cause hypotension, they have drug interactions, there's a number of side effects that occur with them, so there's problems with those. We've been able to add MAOIs to carbamazepine with and without lithium in a small series of people, and one thing that's been remarkable is that it's been tolerated. And if we don't have carbamazepine on board, we're usually pulling out the sport hose and the Florinef and the salt and other things like that to stop people from fainting. We really didn't have those kind of problems with the carbamazepine on board. It was remarkably tolerated. And we actually had a few of these people, 4 out of 10, who got well enough to be discharged from the hospital. So it is possible to use carbamazepine with MAOIs. Gary Sachs has some interesting data on bupropion, pilot data showing that it causes less in the way of manic switches than dizipramine. So this notion in the clinical folklore that it is less likely to cause induction of mania is starting to be borne out in some more systematic studies. Unfortunately, this medicine does have some problems, including some patients getting psychosis with it and seizures at high doses. And potentially, you would think that mood-stabilizing anticonvulsants could decrease both mania and seizures. And carbamazepine not only decreases risk of mania and seizures, it decreases the level of bupropion. So if you have a patient who is on bupropion and is not doing well, and you take a bupropion level, it may come back 0, yet the metabolite level may be 800. These kind of things can happen. So we have to be informed of these possibilities. Serotonin reuptake inhibitors promise to give us fewer side effects. Drug interactions are a possibility, of course. We really, in terms of bipolar illness, need to learn about these medicines. Really need to learn a lot more about them. Kinetic interactions. Paroxetine is actually more of a problem than fluoxetine and sertraline less. So we can think in terms of algorithms for treating mania, whereas in the past it was, the algorithms, you give people lithium, and if they don't respond, they're not bipolar. Well, it's not quite that simple anymore. You have a number of types of patients who will either not respond or not tolerate lithium. They're candidates for mood-stabilizing anticonvulsants. If they don't respond, they should be crossed over. And then basically you're looking into a number of more exotic treatments after that. So dealing with this wide range of medication options, we already have some clinical response predictors. We see that there's a remarkable heterogeneity in our patients, and we really want to work to try to understand that better and predict treatment response so that we can prophylax these people and prevent relapse and possibly even stop disease progression.
Now, Mark S. George, Senior Staff Fellow at National Institute of Mental Health, describes brain activation involving mood and mood disorders.
Many of the studies of mood disorder subjects, we find that this left prefrontal part of the brain, for some reason, is hypoactive. It seems to be decreased either in flow or metabolism at rest. There's correlations with how severely depressed you are. That area shuts off more. And in most studies, it seems to normalize as people get better, irrespective of the treatment modality, that is, either through just following people along, talking therapy, cognitive therapy, or pharmacotherapy. And as people are more depressed, as witnessed by the Hamilton score, in numerous studies, you see this relationship that the more depressed you are, the more that part of the brain seems to shut off. Now, there's only so much information you can get from looking at resting studies of the brain. And I want to tell you that there is no such thing really as a resting brain. If you think about it, it's quite interesting that our brains never really rest. Just like our hearts, that hopefully don't rest during our life, and they keep pumping. Our brain is always active. Even when we're sleeping, there are very important functions going on. And so whenever we take a picture, a functional picture of the brain, it's very important to know what was going on at that time. And this whole concept of activation involves really regulating what people are doing and seeing if that teaches us more about the illness. So what one can do in activation studies is you have someone do a specific task that you think might help you understand more about the brain. Then you devise a control image that has them doing everything the same except for what you're trying to image. And then you can either compare, subtract, statistically image that specific function and where it is in the brain. And what we've found from a variety of studies now is that in subjects who have primary depression, that there seems to be a blunting of activity in those things that are mediated through the limbic cortex. Terry's shown you how ibuprocaine, which is selective for that limbic cortex, there's really a blunting in our mood disorder subjects. And in those neuropsychological tasks that we've had subjects do that involve the limbic system, there seems to also be this blunting. So not only pharmacologic, but neuropsychological activation tasks have the same story. In contrast, tasks that involve cortical areas of the brain, the mantle that is out there, and not the deep lizard brain, actually, they're fine, actually, and our depressed subjects, in terms of their activation, do just as well as healthy controls. So it's amygdala and this kind of circle of the anterior limbic system, very deep, that seems to be dysfunctional. Cortical areas, in contrast, seem to function quite well. One of the first studies in this area was done by Karen Berman and Dan Weinberger, who, as most of you in this room know, have done lots of studies in schizophrenic subjects and have shown that schizophrenic subjects fail to activate the left prefrontal part of the brain when they are doing a task called the Wisconsin card sort. That's a very complex task that requires that you constantly reevaluate the rules of the game. It's kind of like being a politician or being a researcher at the intramural NIH. And you're always having to figure out what the new rule is. And schizophrenic subjects fail to activate the left prefrontal cortex. They also have a performance deficit. Mood disorder subjects actually do quite well. Depressed subjects, they activate the brain quite well, even better than the normal controls. This is in contrast to the study in schizophrenia. Okay, there's another task that I've done, matching the spatial orientation. And what your brain does there is involve kind of a very complex spatial navigation skill, and it activates the parietal cortex of the brain. As many of you may remember from your neurology training, if someone has a stroke there, they may get lost. One of the big problems is navigation. Alzheimer's patients, the brunt of the pathology is there, and they often get very lost. So it activates that part of the brain. In healthy controls, that part of the brain is activated while they do this task. And in our mood disorder subjects, most of whom were clinically depressed at the time of the scan and all are med-free, there's also this same robust activation of the brain. So this cortically mediated task, there really is no difference between our patients and controls. However, when we start having people do tasks that are largely mediated through the limbic system, we find marked differences in activation between patients with clinical depression and normal controls. Two that we've done so far. One involves recognizing the emotion on a human face, and another is a very complex task called the Stroop, which is a way of selecting an appropriate response in the face of a competing response. If you think about it, facial emotion recognition is a very important tool that we have as humans. And actually, for this group of psychiatrists, if you're a baseball pitcher and you want to insure your hand for $1 million, I would think that as a psychiatrist, we would need to be able to ensure this skill, the ability to look at a face and figure out the emotion of the person. That's really something unique that we do as psychiatrists. For years, it's been, well, actually not for a long time, but actually Bob and Dave Rubinow several years ago noted that mood disorder subjects actually have a selective defect in recognizing correctly the emotion on faces. And we know that there are certain neurologic diseases, specifically in the right temporal lobe, where emotion recognition can be a problem. When you look at someone's face, if you look at the person next to you in the room here and try to figure out the emotion on their face, what you do is you actually take the sensory input, it goes to the primary visual cortex, and then it goes somewhere else in the brain. The primary, you interpret it. And the way that you do that is areas in the anterior temporal lobe and the prefrontal cortex. And Dave Rubinau's work showing this selective deficit in mood disorder subjects who, in this task, when depressed, behave like they have a right hemisphere lesion. They're very similar to people who've had a stroke or a tumor in the right hemisphere in terms of not being able to recognize the emotion on human faces. So what part of the brain is involved in that task? If you take PET scans while people are doing this and then subtract, you can, using the techniques that Terry outlined to you in the previous talk, you can get maps of the different parts of the brain. Spatial mapping really involves this where pathway. If you look at something, if I look at the person in the front row and I don't want to know who that is, but I want to know the relationship to the table, I really use this spatial area. If I look at him and say, who is he? Then I really activate this facial identity area. If you think about it, that's something very powerful. If you ever go to meetings around the country, you're sitting in an airport, you can see a face and almost instantly know whether it's familiar or not. It may take you, like me, several days to come up with who it was and where you know them, but it's a very powerful tool that our brains have. Now, when you match for facial emotion, it's anterior temporal, but also left prefrontal, which is the same area that you've heard is consistently hypoactive during clinical depression. So what happens when you have 10 controls doing this task? Emotion recognition. The areas that are activated are the prefrontal cortex bilaterally and these mid to anterior temporal areas bilaterally. So emotion recognition really does use this front part of the brain. Now, the same task in the same way done in 10 subjects with mood disorders who are clinically depressed, they fail to activate this right insula area or paralimbic. They do quite well, actually. They, in fact, solve the task with this cortical area. So there seems to be a blunting of these areas when they're solving this task. So a blunting of limbic activation. Got yet one more task that we've used to kind of activate and probe the brain, and this is the test called the Stroop. I don't know if any of you are familiar with it. Jay Ridley's Stroop actually was in 1910 at Peabody College in Nashville, Tennessee. Described this task where if you have someone read a word, this is the word black, but it's written in blue ink. So you'd have someone read this and say, okay, read the word, but don't say the word, say instead the color that it's printed in. And it gets quite difficult. You start, this word here is red, but it's in green, so you have to say green, and then you have to say blue, then you have to say black, and then you have to say green, but you want to say red. So you're having to suppress a pre-learned response and come up with another one. And you're really having to shut your mouth up while you come with the right response. And in a series of healthy controls, we've seen that the area of the brain that does that shutting up and that selection is left mid-cingulate area. Again, part of the limbic lobe, which is regulating some cortex. And so that's the area that's activated when you do this task. What happens when you have subjects with mood disorders who have problems with attention and have problems with the cingulate? Well, a real lack of activation of that cingulate. Absolutely no activity in mood disorder subjects during this task. This is a slide showing some other things that you can do. You could take a pixel and say, all right, show me, computer, what parts of the brain activate with the cingulate and what parts of the brain are negatively correlated with activity in the cingulate. As activity increases in the cingulate, you get shutting off of activity in language cortex. So kind of a reciprocal play between the cingulate, which is shutting off the language areas. So for some reason, there's this blunted limbic activation in our mood disorder subjects. So to summarize, these activation studies kind of augment this information that we get from resting studies. And to date, so far, we found that almost all tasks that have a marked limbic component, we find deficits in our mood disorder subjects, whereas those that are primarily cortical, there's really a lack of problems. This area is really in its infancy, however, and there are lots of issues that remain before you can fully interpret this. This is from Marcus Reichley in Scientific American, doing the task for the first time and after they've been practicing it up for a couple of hours. As you get more skilled, it takes less brain work to do a task, and you get different activation. So these lack of activation that we seem to see in the limbic system, it's somewhat open to interpretation right now, but it's very interesting that it's all limbic tasks that cause the problem. And if our subjects are not activating the limbic system, then maybe they're solving the task in a different way. That still says, well, why would the brain preferentially go away from the limbic system to solve a task in a group of subjects? So it may actually get us back down to regional neuroanatomy. So I want to move from that overview of that work to the next area, and that has to do with trying to recreate some of the phenomenology of depression. And the way I got started in this was late one night in Bethesda on a Friday night after work. I went to the local Chinese place and was handed actually this, and it said, "You cannot demonstrate an emotion or prove an aspiration, and if there's any way to get me motivated, it's to tell me that I cannot do something." So I promptly set out a way of trying to demonstrate an emotion in the brain. Jose Pardo's work from St. Louis, and what he did in a very quick way and at the end of one of his PET studies was just have his subjects think back to the saddest moment in their lives to take an image while they were self-induced sadness. The area that he got activated was, again, this area that you've heard a lot about today. The left prefrontal cortex seemed to activate, to get more activity when people were sad compared to when they weren't. I saw this, and I actually didn't think it was true. So we set out to show that it was a faulty experimental design and that that was just a memory component. And we designed this study where we had people become either happy, sad, or neutral by remembering events in their lives. It's kind of interesting to look at what people chose out of their life history to go back and think about. Most things involving happiness involved family, friends, children. And sadness were also grief-related, death, illness, separations. And then we had people do a neutral task where they tried to remember something that was affectively neutral. And to our surprise, in Washington, lots of people chose commuting. And we pre-screened those people actually, and they weren't Beltway commuters. They were people who rode the metro. So they were not actually on the Beltway. And we would have people induce their mood state by remembering these, and then we would have, after they're there, view a series of faces that were of the appropriate affect. So when they were trying to be sad, we'd have them look at a series of sad faces. And while they were doing this, we would take the PET picture. Well, very remarkably, what happens when you're transiently sad is you get increased activity, and I feel like I'm repeating Terry Ketter here, in this anterior limbic area, because that is the area that lights up during transient sadness. The anterior cingulate, orbitofrontal areas, and both left and right prefrontal areas. So actually, Jose Pardo was correct. It is kind of left prefrontal, but he missed the bigger picture, is that it's both left prefrontal and this limbic system kind of lighting up. So I'm moving on now to happiness. Any guesses as to what your brain looks like when you're happy? What happens during happiness is you get a little bit of increased activity in the anterior cingulate, but especially compared to what you see in the sadness picture, you really don't get much in terms of increased activity. The major story is that your brain shuts off areas of secondary association cortex. This is the temporoparietal cortex on both sides, and this is the right prefrontal cortex. So during transient happiness, it is the case that relatively you have less activity in these cortical areas. It was at first quite surprising to us, but then as we read the literature, this has also been found with euphoria induced by morphine or cocaine, and it's also true in the procaine data set that those who got euphoric had relatively less activity in these areas. So as Dr. Post once said to me, instead of when you're happy and you know it, clap your hands, when you're happy and you know it, shut off your secondary association cortex bilaterally and right prefrontal. It wasn't funny when he said it the first time either. Okay. The other very interesting thing that I want you to take away from these studies is that we have neuropsychologically induced a mood state, sadness. And Terry has shown you how pharmacologically you can induce a mood state, and we get the same area of the brain lighting up. So this really is the emotional regulator of the brain. And it is the same area that seems to be blunted in terms of neuropsychological activation in these other series of PET studies. There's a very interesting story to be told about what's going on in the amygdala, that very small structure that's quite important in terms of our emotional life. When you're sad, both your right and your left amygdala seem to increase in activity as you are more sad. So the sadder that you are, these are post-hoc ratings. We would ask people, how sad did you get? And this is a correlation between blood flow in the amygdala and their self-rated sadness. More sad, both right and left go up. Interestingly, your left amygdala really cares about whether you're happy or not. Your right amygdala will go up no matter what the emotion, but this left amygdala seems to be shutting off during happiness. So there may be within this circuit of the anterior limbic system very subtle differences in activity relative to each other that determine the actual output of either anxiety, happiness, sadness. So you've heard a lot of kind kind of contradictory things. The left prefrontal cortex seems to be hypoactive during states of clinical depression. Paradoxically, it's the area that seems to turn on or be activated when you're transiently sad. How do you begin to integrate those kinds of things, especially in relationship to Dr. Post's earlier talk about the relationship between grief and early life stresses and the later development of clinical depression? Is there a way to begin to start integrating, just at a neuroanatomic level, some of these divergent bits of information? It leads us to think possibly in parallel to another disease, that is epilepsy. Again, not in a kindling way, but in a different way. What's been found in the epilepsy literature is that when you have a focal seizure, during a seizure, there's marked hyperactivity at the site of the seizure in terms of blood flow. Postdictally, that area really shuts off. That area goes into hibernation. And interictally, there may be asymmetries. So during seizures, it seems like there's this increased burst and then later kind of falling away. Now, this takes place on the course of an hour. The question is, could something like this be happening with grief reactions and increased activity in limbic cortex and left prefrontal, and then shutting off or blunting later as the disease progresses? Relative to the rest of the brain, that area of the brain is really hyperactive. And is that going on when people are acutely mourning? And does that have long-term consequences for the development of affective illness? Well, let me move now to the last area of activation. One way of activating the brain is to actually go in during surgery and electrically stimulate. Now, as psychiatrists, we don't do that, and that's fairly invasive. But we've recently developed a technique that is non-invasive that allows us to do essentially that same thing. And let me just show you the future. And that has to do with a new technique called transcranial magnetic stimulation. That is, placing a small magnet on the surface of the skull or on the scalp and turning it on and off very rapidly. It can produce transient changes in magnetic field which can excite the underlying nervous tissue and cause you actually to move your thumb if you do it over the appropriate motor cortex, or your leg over the other area. It's relatively non-invasive. It feels kind of like your head's getting tapped with a hard eraser. It's relatively painless, and it can stimulate, or if you stimulate at a certain frequency, it can temporarily take an area of cortex offline. It can make it kind of tetanic, and it can temporarily disable that underlying cortex. For years it's been used to study motor cortex, and I and others have been using it now to begin to investigate the local anatomy of mood. And you can produce very focal changes in underlying magnetic field, which can also then have an influence on the neurons.
Dr. George's remarks continue on Side B. Side B, Audio Digest Psychiatry, Volume 24, Number 9, returns to Mark S. George on studies of brain activation and mood disorders.
So a magnetic field change in underlying neurons can cause the nerve cell to depolarize. Right under the cortex, you've got a nice area of spread of magnetic field. If you go a little bit further, or if you go just a couple of centimeters into the brain, it falls off rapidly as you go away from the source of the magnet. So really right now we're just limited to stimulation studies of this cortex. We can't get at the deeper limbic system in terms of direct stimulation with this technology yet. However, it has been used so far to begin to activate and study mood. This is a study from a colleague of mine in Spain, Alvaro Pasquale Leon, who used to work at the NIH. He did this study earlier in the year. He's a neurologist, and he showed me these results, and I knew that they were wrong, actually. What he found was that if you stimulate over right frontal or left frontal, that you get divergent effects in healthy volunteers on self-rated mood immediately afterwards. It was all mildly painful. Everyone got a little more tired afterwards. The right frontal caused an increase in happiness, whereas left frontal caused people to really self-rate less happy. That's confirmed by the sadness scale, where left frontal caused a statistically significant increase in sadness. So stimulation over that left prefrontal cortex, the same area that you've heard is shut off in clinical depression, that activates during sadness, makes healthy controls sad, and that is regionally selective. That's specific to one side of the brain versus another. Well, I thought this was unbelievable. I said the brain doesn't work that way. It's not that simple. So over the course of the summer, in the hot August months here in Washington, I've done a somewhat better study where we scanned, again, 10 healthy controls, and we used a stimulation paradigm, which is a little less intensive than what they used in Spain. And we found that Right prefrontal stimulation really did cause increases in self-rated happiness stimulation. Right prefrontally caused happiness, and stimulation over left prefrontal caused significant sadness in subjects. I should tell you that none of these were clinically apparent. These people did not walk out saying, I feel sadder. And it's just statistically able to be picked up when you do fairly large groups, 10, and use statistics. But it is, at least now, a very consistent pattern that stimulation of these different brain regions can affect mood and healthy controls. So how is that going to influence the clinical practice of psychiatry? Well, it could be that since we can change mood and healthy controls, that we can use this as a therapeutic tool to change mood in our mood disorder subjects in a way analogous to ECT, but radically different from ECT in that we don't have to induce a seizure and we don't have to have generalized anesthesia. The first attempt at this was by Hofflick, who tried to run up to ECT and really found no effect, but he used doses very sub what we use now. This notion of shutting off parts of the brain and producing a therapeutic response is not as far-fetched or Buck Rogers as you might think. Studies from Ebert in Germany and Joe Wu in California showing that if you image depressed subjects before they have a night of sleep deprivation, that those people who respond to sleep deprivation on their baseline scan have increased activity in the cingulate, which then shuts off the next day. So somehow sleep deprivation in this group has shut off the hyperactivity in the cingulate. Those who don't respond at baseline did not have hyperactivity in the cingulate, and there's no change. But you can see that sleep dep can transiently shut off these areas of the brain and produce a therapeutic effect, and we think that possibly with this new non-invasive TMS we might be able to do the same. So I hope that has helped you to integrate some of the new knowledge in terms of regional neuroanatomy and our understanding of the pathophysiology and hopefully ultimate treatment of mood disorders as we use these windows into the brain to make ourselves better clinicians.
To conclude this issue, a look at side effects of lithium by James W. Jefferson, Distinguished Senior Scientist at Dean Foundation for Health, Research, and Education, as well as clinical professor at the University of Wisconsin. He starts with benign cognitive side effects.
These are really the subtle side effects that I believe many people get, fewer people complain about, and many doctors don't recognize them as a cause of potential noncompliance. So people can be less spontaneous, their reaction times can be a bit slower, they do a little less well with the video games on lithium, they have spotty problems with memories, a sense of unpleasant dysphoria, and in many of these people it's not merely the absence of hypomania, but it appears to be a pharmacologic effect of the drug. It's subtle enough that it could be caused by other factors, and in fact, if one has a patient with this type of complaint, I would suggest you go down a checklist and first say, does the patient have lithium-induced hypothyroidism, because hypothyroidism impairs cognitive function, and it's very easy to check with the TSH, and it's very easy to treat with the addition of Synthroid or T4. A lot of patients have breakthrough depressions on lithium, and lithium may attenuate the severity of the depression to the point that the patient isn't quite sure whether he or she is depressed, but they know something isn't quite right in terms of how they're thinking and functioning. And in these situations, the treatment obviously has to do with, does one intervene further to treat depression rather than deal with the neurological side effect. The majority of patients maintained on lithium are also maintained on other medications. This is becoming clearer and clearer. Some work that Gary Sachs has done in Boston, and I believe it showed something like only 11% of lithium long-term patients are on lithium alone, so that other medications may contribute to this type of side effect, the anticholinergic and sedative side effects of antidepressants and neuroleptics, for example. Right in here, let's put and keep in the back of our heads the fact that lithium can basically reset the calciostat. Sounds like something to do with lights, but basically what it does is causes a mild hypercalcemia in anywhere up to 40% of patients. And almost always this hypercalcemia is asymptomatic and something that's noted incidentally if you do chem panels periodically. But if the calcium level gets too high, it can cause a sense of fatigue and a sense of weakness that might be misunderstood as a more direct CNS effect of lithium. So in these situations, you might want to do a general chemistry screening to look for other possible etiologies. And beyond that, The only acceptable other treatment is, can you get away with a lower serum lithium level or a lower dose? And unfortunately, you're really gambling if you're trying to lower levels without a risk of relapse. That's pretty much what one tries to look at with the non-toxic neurological side effects. Now, tremor. Tremor has been, ever since lithium came along, tremor has been a very well-known and generally benign lithium side effect. Let me suggest that there are a number of different types of tremor, and while most commonly one develops what's officially called a postural or physiologic or essential type of tremor, and this is what everybody has when they hold their hand out, and this is what everybody has when they get up a little too early after a night out and they sort of look at their hand, and this is what speakers have when you try and follow their dot when they're holding a pointer up, and this is why speakers, of course, take beta blockers. At any rate, this is the common type of tremor. With long-term lithium therapy, some patients will have a slowing of tremor frequency down into the Parkinsonian range, and they may develop a bit of a Parkinsonian rest tremor and a bit of cogwheeling that can be present even in the absence of associated neuroleptic treatment. But this tends to be somewhat uncommon. The toxic tremor is basically an exaggerated postural tremor. And this should be a warning if a patient comes in and says, I used to shake a little bit, but now I shake a lot, and you see their jaw going up and down. That's the time you think of impending lithium toxicity, stop the drug, check the level, and be on the safe side. Finally, here we have an intention or cerebellar tremor, and this is the tremor you get if you don't check the blood level, and if the patient does get toxic and gets neurologically damaged and survives, the most common long-term neurological consequence of lithium intoxication is a cerebellar syndrome with a rather marked intention type tremor. So those are the four that you have to consider in patients on lithium, but most commonly it's postural, and it is a tremor identical to the tremor that occurs commonly with valproate. So you might expect patients on combinations of lithium and valproate to have an exaggeration of this side effect with both medications. What can you do about it? Well, fortunately, in most patients, lithium tremor gets less and less with time, and most people tolerate a tremor quite well. Some folks are involved in occupations that are demanding of very fine motor control, and their tolerance for tremor is very, very narrow. Now, I once treated an ophthalmologist who did microscopic eye surgery with lithium, and can you imagine even a very small tremor under the microscope can be very problematic in that situation. So it depends quite a bit on what the patient does, whether they can tolerate, and weight out improves over time. Lower the dose improves just about any side effect if you can get away with it, but there is this tendency towards higher maintenance doses going on these days, for better or worse. Some people think control-release preparations are better for tremor because in some patients, tremor seems to correlate with peaking of blood level following absorption of the drug, and the slow-release peak level is considerably lower and spread out over a longer period of time. Lithium plus antidepressant, lithium plus valproate, lithium plus antipsychotic will all aggravate a lithium tremor, so sometimes you can take away other drugs. Patients who are particularly anxious will also shake more in the presence of lithium. So those are pretty basic types of interventions. Things can get a little more exotic if the tremor is persistent and troublesome. Get caffeine out of the diet because caffeine aggravates tremor. But keep in mind that caffeine, being a xanthine-type diuretic, actually increases renal excretion of lithium. So if the dietary caffeine content goes from very, very high to very, very low, the serum lithium level may increase in response to that, and you may have a paradoxical worsening of the tremor in association with the elevated lithium level. But that's really an exceptional occurrence in these patients who are 4 or 5 pot a day coffee drinkers. Propranolol has been the standard drug if a drug has to be used. And I don't think there's anything unique about propranolol except that it was there first and people studied it, and people reported about it, and doses 20, 40, 60 milligrams a day seem to do the job. The neurologists are using primidone, mycilene, as a drug to treat benign essential tremor. There's been a little bit of work done with lithium tremor, and the suggestion is that 50 to 250 milligrams a day of primidone will have an anti-tremor effect in lithium patients. So beta blockers and primidone are the two pharmacologic interventions that are reasonably well established. Primidone is metabolized to phenobarb, but in the essential tremor literature, primidone works and phenobarb doesn't work particularly well, so it seems to be something with the original molecule. Evening primrose oil is a big question mark. I don't know, how many people use primrose oil for treating patients, cooking, applying to your own body later? No, forget it. Okay. Potassium. Potassium is interesting, especially in animal studies. Animals on low potassium diets have substantially more lithium side effects in just about every organ system than animals at the same lithium level with normal potassium intakes. And there's some evidence that potassium can reduce lithium tremor. Now, the evidence is not strong enough to suggest potassium supplementation, but patients on lithium should be encouraged to ensure that they have a very generous dietary intake of potassium. And that'll come up again in the area of polyuria. Inositol, which is the precursor in the second messenger phosphoinositol system, has been shown in limited applications in doses of 1 gram 3 times a day to have some tremor-reducing effects. Now, this is totally anecdotal based on a handful of patients, but this substance will pop up again in a number of different areas. So if you're sort of looking for odd and probably very benign types of interventions, keep inositol in the back of your head. Now, primidone, of course, being an anticonvulsant, one wonders whether or not you could get not only a tremor reduction, but what about a little bit of mood stabilization at the same time when it's combined with lithium? This is a single case report of a rapid cycling bipolar patient. It appeared in the Lancet in October '93. And prior to 1986, this patient had manic and depressive episodes frequently. He or she was treated with lithium, and lithium totally suppressed the manias and converted this person to a rapid cycling depressed patient. So these are just depressive episodes happening year after year after year in the presence of lithium until the patient was placed on primidone for a lithium tremor. Once the primidone dose was stabilized, the depressive episodes went into full remission, and at the time of publication, which was 3 years beyond this date, the patient was still euthymic on the combination of primidone and lithium. And I assume they weren't shaking very much at the same time. So it's an intriguing combination that really hasn't been explored very much. Headache. Most psychiatric drugs can have headache as a non-specific complication. Patients on lithium who complain of headache deserve a little closer investigation and evaluation than just non-specific headache. So if somebody comes in and says, well, I've been on this drug for the last 6 months and now I'm getting these headaches that are quite severe and non-specific, the next thing you do, because you're doctors, is you take out your ophthalmoscope and you take a peek at the eye grounds, and if you see papilledema plus headache are often associated with, are characteristically associated with pseudotumor cerebri, benign intracranial hypertension, which has been reported in probably 30 patients or so on lithium at various stages of treatment. So it's a rare but reasonably well documented lithium side effect of unknown mechanism. Fortunately, it tends to resolve, although slowly, following discontinuation of lithium. So before you take your pseudotumor patients and send them off for a shunt or to have their optic nerves decompressed, because the long-term complication of this disorder is blindness, stop the lithium and get into the area of alternative mood stabilizers. Now to the morbid part of my talk. Lithium intoxication can kill people. And that's important to recognize. We're talking about a relatively narrow therapeutic index drug. The extreme outcome of toxicity being death, and the next worst outcome of toxicity being neurological damage that does not go away over time and is often but not always cerebellar. But characteristically, if you have a severely toxic patient who doesn't fully recover, they will be walking around with a wide-based gait and an intention tremor, and they will have very slurred speech, and that's characteristic lithium neurological damage. So it's nice to avoid these problems. That was sort of obvious, yeah. But strangely enough, they occur for very obvious reasons. No one in this room would have ever done this to this patient. This is a 62-year-old woman with manic depressive disorder who started to become manic somewhere in Wisconsin, and whoever was treating her must have opened up the PDR and read the package insert that said, for acute mania, use 600 milligrams 3 times a day. And they closed the PDR up and put her on it, neglecting to realize that she was somewhat elderly. She had cardiac disease and was on a low-salt diet, and she was already taking a thiazide diuretic. So she had most all of the risk factors for intoxication: too big a dose, old kidneys, low sodium intake, and a lithium-retaining drug, and within a week she was in the ICU. No one would ever do that. The other point, though, is while you may have your patients on very therapeutic amounts of lithium, they may be sneaking off to their internist, who is treating, unbeknownst to you, their hypertension with factors like this that can precipitate toxicity. So patient education becomes vitally important. Well, let's assume the patient is intoxicated and you want to get lithium out of the body quick. In the presence of nice, healthy, reasonable kidneys, lithium is cleared at a rate of 15 to 30 cc's per minute. That's normal. Peritoneal dialysis does not improve on that. So same type of clearance with peritoneal dialysis, which makes it a not very useful intervention unless you don't have access to other techniques, and if the toxic patient has impaired renal function. This is very common with lithium toxicity for the kidneys not to work well. And in those situations, peritoneal dialysis is better than nothing. Now we go down to hemodial filtration, which is a variation on hemodialysis that is done more slowly over longer periods of time using a hemofilter in the circulation, and that will push the clearances up to 25 to 30 cc's per minute. The advantages are it doesn't require an as elaborate setup as hemodialysis, and it can be done continuously for long periods of time. But the bottom line is hemodialysis gets it out fast. The clearance up to 168 cc's per minute, so you can increase the rate of lithium removal from the body by a factor of many times with hemodialysis, and that makes it the route to go when a patient is neurologically impaired with a high lithium level. And somebody's going to ask later, how high does it have to be? It's a clinical judgment, and you balance the duration of exposure to lithium, the clinical status of the patient, and the serum lithium level and how fast it's falling without treatment. There's no set level at which one dialyzes. So treatment of choice for severe intoxication. Severe is in the eyes of the beholder. Keep in mind that patients can walk in with a lithium level of 6 and look very good until 1 or 2 days later when they're comatose, so don't take for granted the initial clinical presentation of the patient. Beware of rebound intoxication. Now basically what happens when one dialyzes is that lithium is very rapidly and effectively removed from the blood. It's a non-protein bound water-soluble element basically. And once dialysis is terminated, lithium comes out of the tissues back into the blood and re-equilibrates, and the blood levels go back up again. So sometimes one has to dialyze a number of times to keep the level low. Now the story of the lithium bezoar is educational in a number of ways. This was reported in the Annals of Internal Medicine in '92. And it shows you what happens when somebody comes in lithium toxic from an acute overdose with a level approaching 4 milliequivalents per liter. Dialysis, the level comes down rather quickly to a little above 2, but dialysis is stopped, the rebound appears, and the level pops up to 3 or so. And in fact, patients may look very good down here and appear several hours later re-intoxicated. That's a characteristic picture. Dialyze again, the level goes down lower, and normally it continues down like this, but in this case, the rebound now is almost back to where it was. And then finally, after another dialysis, the patient ends up with a level higher than they had on admission. Now that's not much progress 84 hours after the overdose to be in this situation. And they decided the patient had to be having continual absorption of lithium from somewhere in the body, and they assumed it was the stomach. They stuck an esophagoscope down, and lo and behold, there was this aggregated mass of lithium carbonate sitting in the stomach, gradually dissolving and pushing the blood level back up and back up and back up. This was a 5 to 6 centimeter in diameter mass of lithium. And by way of comparison, your normal golf ball is 4¼ centimeters in diameter. They broke it up, removed it, dialyzed once more, and the levels went down. The patient lived happily ever after. One has to monitor lithium levels continuously during the treatment of intoxication. Hypothyroidism, and years ago you'd say hypothyroid patients lose the lateral third of their eyebrows. Now we have to consider a differential diagnosis of trichotillomania in situations like this. But this lady is obviously myxodematous. And keep in mind that if someone gets severely enough hypothyroid, they can become psychotic. This is the old term myxedema madness. They can look depressed, and one would call that a pseudo-depression or an organic depressive disorder or what have you. But interestingly enough, a certain percent of hypothyroid patients will present with anxiety, irritability, and insomnia. So one has to be very attentive to these diverse presentations in patients with lithium because lithium suppresses thyroid function. And about 5% of patients, roughly speaking, will become clinically hypothyroid on lithium, and most of these patients are women. So, how do you prevent this? Well, you monitor thyroid function either at regular intervals of every 6 to every 12 months, or you monitor the patient from a clinical point of view, and any time something is not going right clinically with the patient, part of the evaluation is a check of thyroid function. And I would suggest that doing TSHs frequently in patients who are unstable makes an awful lot of sense. Now I say check the eye and the neck. There have been a few reports of exophthalmos occurring in the presence of lithium, unrelated to pseudotumor, and apparently related to effects of lithium on the eye. So if somebody walks in and you think they're staring at you, now this lady actually is hyperthyroid, but this type of exophthalmos, while very rare, has been described in non-hyperthyroid lithium patients. Occasionally people on lithium can have hyperthyroidism, which sounds paradoxical because lithium tends to suppress thyroid function, but that has been described. And again, the TSH holds the answer. When do you supplement a patient with T4 or Synthroid? Anytime there are clinical manifestations of hypothyroidism, add T4, adjust the TSH back into a normal range, and the patient can go on happily ever after. Maybe not so happily ever after, but euthymically ever after. Now, chemical hypothyroidism. The lab tests are abnormal, the patient looks fine. And the rule of thumb there, and again, I'm not going to be able to give you an absolute number. The rule of thumb is that mildly elevated levels of TSH tend to normalize despite continuing lithium. Marked elevations of TSH tend to go on to develop clinical hypothyroidism. So if it's up a little bit, do nothing but monitor thyroid function, and it will generally normalize by itself. If the patient's doing poorly with affective lability, rapid cycling, or bizarre side effects, I would always consider a trial of thyroid supplementation in those situations. The dose of thyroid one would add for long-term treatment in a lithium patient would be using T4 and starting with a conservatively low dose, perhaps 0.05 milligrams, and just titrating it up until the TSH comes back down into therapeutic range. We're not talking about hypermetabolic doses for treatment-resistant rapid cycling in this situation.
Dr. Jefferson's survey of lithium side effects continues on your next issue of Audio Digest Psychiatry, produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. This tape is copyright 1995.